Please join me in welcoming Dr. Al-Khathaami.
السلام عليكم ورحمة الله. جزاكم الله بالخير جميعاً. Good afternoon, everyone. Thank you so much for the organizer for having me. I'm really honored and privileged to be here today. Today, in the morning, we saw the great vibes of the transformation and how 2030 has transformed our health system, and the great successes and achievements that has been made through the last 5 to 6 years. And patient safety science and patient safety initiatives, and Saudi Patient Safety Center is not an exception. In fact, we are in the same boat. So thank you for everyone who contributed into this success. Proud nation, and we should always be. What I'm going to do today, I'm going to talk to you about the current and the future diagnostic safety in Saudi Arabia. Dr. Wazan has highlighted beautifully the burden and at a higher level the way how we should move forward. But before I get into my presentation, I wanted to ask you one question. How many of you have seen or met or heard someone who had an experience with diagnostic errors? Hands up. Quite significant numbers. And this is consistent with what Dr. Wazan has highlighted in his presentation. It's a common problem. It's a very prevalent, and we are not an exception. And it's everywhere in the world. It's one actually of the major sources for preventable harm. So in general, every 5 to 10 diagnoses, one will be wrong and incorrect. And if you walk into the outpatient department, every 20 patients will have one wrong diagnosis. And in the autopsy studies, it showed that 10% of deaths is attributed to diagnostic errors. In the United States only, and every year, it is estimated that about as high as 1 million people has either permanent harm or mortality due to diagnostic error. Yes, we do not have a very robust local data, but we share with the rest of the world the same challenges and opportunities. So, I think I have a problem with my presentations. I think the font has changed. But what I'm going to discuss with you today is that since 1999 and the famous publications that has brought the focus on patient safety, and there have been a lot of advancement. There have been a lot of movements. And there has been significant reduction in harms in different domains, especially when you talk about medication errors, preoperative care, hospital-acquired infections, and when you talk about nursing care-associated harm. However, when you compare the movement that has been made in the diagnostic safety and preventing the diagnostic error, you could actually notice that the movement is not as fast as we wish. There is some progress, but in fact, it has been a bit slower. And the reason for that are many. One of them is that we lack the common understanding of the diagnosis of, or the definition of diagnostic error. The other things, we do not have, at least in Saudi Arabia till this moment, the framework for measurements. We do not have the tools, the standards, protocols. We're very familiar with the Sibahi and JCI chapters when it comes to nursing care, safety and medication administration and prescription, and dealing with infection within the hospital. But unfortunately, we don't have that safety kit yet that organizes the field. And many of us wanted to do something, I wanted to start, but we don't know where and what. So many people think that diagnostic errors is all about doctors. I am practicing neurologist and I make mistakes, and the last mistake I've done was last Tuesday. If I have time at the end of the presentation, I'll share it with you. But even great doctors can make mistakes. So if you look into the diagnostic errors or the diagnostic excellence, the opposite, having the right diagnosis in the right time is not only about doctor. It's a product of the entire system. And that system has the physicians, the other healthcare providers, the patients, the families, the disease, and the component of the system. I always tell people having the right diagnosis in the right time is like scoring a goal in a soccer or a football match. You could have the best players, Messi or Ronaldo, but they cannot score by themselves. They cannot score alone. They need the team, not only in the field, but also the team members outside the field. You know, the entire ecosystem of the club has to work in order to win the championship. So when you look into things like diseases, I think we have, I don't know if the pointer is working, but when we look into the diseases, for example, we have 200 symptoms and more than 10,000 diseases. And just imagine the overlapping between symptoms and diseases can be misleading for physicians and healthcare providers. We did not learn the 10,000 diseases in medical school. Maximum of 1,000 or 2,000. The best of us actually knew the 2,000 or 1,000 diagnoses. And there are new discoveries every day. There's a new diseases. There is a new symptomatology. There is a new features. Diseases are very dynamic. They change over time. They're complex. And they are now associated with tons of comorbidities that actually influence the manifestation of diseases. So it can be tricky sometimes to diagnose these diseases. Some of the diseases do not have a diagnostic test. In my specialty, for example, in neurology, many of our clinical conditions, we don't have that magic test that tells you that, oh yeah, it's a positive, negative, it's you have the disease, you don't have the disease, but rather we use our collective wisdom and, you know, judgment and experience and all of this. So we are prone to, you know, diagnostic errors. When you look into patients express their symptoms differently. And the way how we express ourselves and our symptoms or disease manifestation is based on our language and our cultural background and our cognitive abilities and our psychology, whether we are anxious, we are stressed out, we are depressed, and many other factors. And when you look into the doctors, for example, no matter how good you are as a physician, how many physicians we have here? Hands up. Great. I'm sure you're great, but no matter how great you are, you're going to do a diagnostic error. And the reason for that, yes, clinical knowledge, skills, competency, communication skills are very important. But even in our best situation, when we are relaxed, we have no pressure, brain sometimes can make mistakes. So those are the cognitive errors. So our clinical reasoning and decision-making process and cognitive biases, we did not learn it. I have done 2 residencies and 1 fellowship inside the country and outside the country. I did not receive a formal, explicit training in clinical reasoning and decision-making and the cognitive errors and the way how the brain make a decision and making the diagnosis. So, Going back to the system, which is very, very important, we have a lot of challenges. Patients sometimes wait for sometimes weeks, months to see a specialist. So access of care is a challenge. Access to diagnostic is a challenge. I know sometimes people can wait for the MRI for 3 months, 4 months, right? To get their brain scanned for tumor. That's a very important and issue. The referral process between primary health care, secondary care, tertiary care, and between the teams and between the different silos in the system and the disintegration and the fragmentation that we have, the patient gets lost between these silos. The flow of the informations and the data between these components sometimes gets lost. Someone who, did a woman did a mammogram, and 6 months or 8 months down the road, she realized that her X-ray that was done 1 year ago actually was positive for cancer, and no one actually flagged it. That's quite common in healthcare. We also have problem with the teams and team structures and team competency and team training, how we talk to each other, how we communicate, how we do handover, how we address the plan of care together, not only within the same team, but the consultation services, specialty to ER consultations, primary health care to secondary care, and so on. We also have a problem sometimes with the structure of the infrastructures, electronic health records, and the optimization of the technology. We might have problem using some of the technology, right? If it's not available, and if it's available, sometimes the way how we optimize it to be patient-centered care. And I also wanted to highlight one important thing. We were not trained to diagnose patient in telehealth or telecommunication or telediagnosis. This is something new. So telemedicine, it provides a lot of opportunities to improve patients' care, but also we should be trained how to make a diagnosis and the correct diagnosis remotely. So this is something that we need to think about. I'm not going to talk about how the brain, I'm a neurologist, so I'm very interested in the frontal lobe and how the frontal lobe can make decisions. But basically the way how we make a decision as a healthcare providers, our brains swing between two systems, system 1 and system 2, and they are different, and this is what makes us make a bad decision in life. I'm not going to talk about this, but this is something that you might be interested to explore later on. Yes, we are under pressure. We can be tired. We get exhausted. If I'm on call and they call me 3 o'clock in the morning and I come to the emergency, next day I'm not going to be fully functioning as usual. I can be depressed. I can be anxious as a healthcare provider. But even in my best situation, brain can make mistakes. And that's what we mean by cognitive biases. So basically, the brain can just jump in and take shortcuts, can ignore some important information, can fixate on something. So if I am a stroke neurologist, everything in my eyes is a stroke. And if someone is rheumatologist, everything in the eyes of rheumatologist is lupus, right? So it is very important to be aware of this. The whole idea of showing this is not to discuss the different cognitive biases, but to tell you as a healthcare provider, we were not trained to use these tools, and we are not fully aware of this. How should the future look like? Well, the optimum or the optimal destination will be having a diagnostic excellence. What does that mean? That means accurate and correct diagnosis in the right time, that is effectively communicated with the patient, and the whole diagnostic process is designed around the patient, so it provides an exceptional patient experience, and it should not be costly. So it should use the minimum possible resources, and it should avoid over-diagnosing and over-testing. So this is, again, if we push this side, we might end up having another issue with the over-diagnosing and over-testing. Not only because of the cost, by the way, it is very important to be cost-effective, but over-testing and over-diagnosing is another source of patient harm. So where are we as a nation? Thank you so much for the Saudi Patient Safety Center. They're working hard on the strategy. I am sure they have sometimes to communicate that with you, but I know that there is a huge work going on there. We know that they already have stated that diagnostic errors is a national priority for the center. However, in this point of time, as a Saudi health system, we do not have a unified national definition of diagnostic errors. So we do not speak the same language when it comes to measurements, into the standards, the practices, the tools, and we do not have clear roadmap, and hopefully it's coming soon, inshallah. The healthcare organization's commitment to address diagnostic errors, I have to say, we haven't been tested very well. I am sure the response will be great, but we need to make sure that we have a buy-in from the leadership of the healthcare organizations. We do not have data, and I think we need to prioritize research on the top of the agenda. However, there are very reasonable international data and experiences on diagnostic errors, especially from United States. The National Academy of Medicine with the ARC and the other collaborative work that came since 2015 is very inspiring, and I think we should be open to basically follow those systems and even innovate and create way above and beyond those initiatives. So from here to there, it's a journey, and it's not an easy journey, I have to say. Having my experience working on patient safety and quality, this journey looks like this, but once you start to drive, I'm sure you will reach the destination. So what do we need to know as a nation? Well, we have to do a lot of things at a national level, at a health organization level, and health sectors, at provider levels. And I'm just going to go briefly over what do we need as a nation. Well, we need a national statement. I think national statement is very important to put the diagnostic safety as a key priority for the entire ecosystem. Not for certain organization, not only for the safety center, for the entire ecosystem. We also need to have our Saudi diagnostic safety kit. We have to speak the same language in terms of definitions, standards, practices, measurement framework, and the way how, and the roadmap. We also need to start to build expertise. I'm sure in this room there are a lot of expertise in diagnostic errors. We need to get together and make sure that we work together. And I would propose today that we, after this forum, we should have diagnostic excellence network across the country, not only in the central region, but all over the country. Integrate diagnostic safety and clinical reasoning and decision-making and cognitive biases and errors into medical education. Again, I have learned these things recently, although I've been practicing for a while. And I have to say, it changed my practice. The way I think about diagnosis is different after learning this. I think the Saudi, the curriculum at medical schools and in the residency and the fellowships should address patient safety in general and the clinical reasoning and decision-making in specific. We need also to integrate diagnostic safety into accreditation activities. I was actually looking into Sibahi and JCI and other, No offense for Sibahi, but I did not find the term diagnostic safety and diagnostic error explicitly presented in the chapters. There is no diagnostic safety chapter. There is nursing practice chapter. There is a medication safety chapters. There is OR and preoperative chapters, leadership chapters. We should have diagnostic safety chapters, and we should enforce the practices. And hopefully that should happen in the near future. We do not have priority to fund patient safety research. And I think having the new entity, NIH, sure if someone here from NIH and other funding agencies, we should really make sure that the priority comes to the diagnostic safety research and patient safety in general. We should work together to build some program, and I will be very interested after this conference to, if someone is interested, to work together on diagnostic excellence. What do we need at a level of organization? Many of you belongs to healthcare organization, and I think what we need is that we need to buy in. We need to realize that this is a problem and we have to respond to it. So the commitment is very important. The accountability is very important. But also, we need to be structured and systematic in approaching this. So I do believe that each organization, especially the big organization, should have a program that is very well structured, very well governed, that focus on diagnostic error and diagnostic excellence. These programs should have a clinical lead, reporting system, and typically should report to the top of the organization. We should actually encourage speaking up about diagnostic errors. Physicians, including myself, we do have this kind of ego, right? But we should be open to talk about diagnostic error. We should be open to report it. And we cannot reach that unless there is a patient safety culture, there is a just culture, there is a just policy that actually address the concern of everyone. If there is no blame, no shame culture in the organization, everyone will come up and bring the problems and bring solution in the same time. I also wanted to have system in place to learn. The analysis and feedback to the physician is very important. We also need to use the technology, and not the technology only in making the diagnosis, but the technology how to enhance diagnostic excellence by giving a real-time, immediate feedback to the physicians. We also need to build expertise. I mean, then patient safety is science. We need to localize the science. We need to transfer knowledge to the organization. We need to build the teams from inside. We need to work on our physicians. We started this in my organization. I work for National Guard. We started to build teams to train physicians on cognitive biases and clinical reasoning. And we need to work on our teams. It's very important to, and there are many tools out there. Thank you for the experts who provide us with the tools, how to build teams, how to enhance communications, and they are available. And I will be very interested to share with you these informations after the presentation. As a healthcare providers, and specifically as a physician, what do we need? We need to understand that we're human and we make mistakes. And it's not shame to make mistakes. The shameful part of it is not to learn from it. And I think that's a very, very important. We need to engage directly in building this program. These are new initiatives, new directions. We need to be very adaptive to technology. I think today we have a debate, should we use AI or we should not use AI? I think that we should be beyond that discussion. I think the discussion is what to do to regulate AI rather than should we use it or not. I think we should be very open as a physician and adaptive to use the technology. I'm not going to talk about the future. The future is great and the innovation is massive. The technology is enabling, including AI and machine learning. the access to diagnostic, especially the telemedicine and remote diagnostics. You can actually reach any experts anywhere, anytime, in no time. We have seen today the virtual hospital, the biggest hospital in the world. This is really amazing. We need to enable our electronic health records with decision support systems, wearable technology, cutting-edge advanced diagnostic is very, very important, and I think there will be some sessions addressing this part. So, if any one of us wanted to walk out of this room and do something, what should I do? Well, I think there are some experiences that worth looking at. I think the experience of the National Academy of Medicine, the ARC, and the working with the Leapfrog group is very interesting. They just published 29 standards. And I looked at it, and it's really very beautiful. It can guide us what to do. And when you look into the 29 standards, they basically, you can divide them into about 6 domains that you need to be aware of. One is having a structured program that look into the diagnostic errors. The second thing is working on physician engagement, training, cognitive errors, decision-making, clinical reasoning, and all of this. The third thing is empowering patients. Last night, one of my relatives called me. He said, well, I did some blood tests today in the outpatient, and there are a lot of red stuff in the application, and she doesn't know what to do with it. And I was called the team. Did we empower the patients? Last week, we were talking about the critical result. Text message that goes to the doctors and go to the chairman to close the loop. And I said, why we're not texting the patient? Why we're not empowering the patient to own their health? Actually, to mobilize the resources for themselves. So working in the patient is another domain. Medical condition and disease. Maybe at the beginning, focusing on those diseases that are very sensitive to time, like cancer, vascular diseases, strokes, MI, sepsis is very important. System enhancement. And I'm going to share with you an experience from National Guard where system enhancement and system using innovative way, cost-free, can make a huge difference. The other thing is learning. If we don't learn, there is no point. So I'm going to just to share with you some of the things that I have been involved in a direct way or indirect way with the National Guard group. We have focused on the time-sensitive medical conditions, mainly sepsis, stroke, MI, in-hospital deterioration, and sepsis. And we worked on the other domain, which is the missed incorrect diagnosis. And all of these came from the safety reporting system. We receive about 45,000 safety reporting system a year. Through the analysis, the system identified many of these. All of them are enabled by technology, and all of them are automated. I don't have time to go through them, but I wanted to share with you the early detection and diagnosis of sepsis in National Guard. The group led by Prof. Yassin Arabi, he just received the Lifelong Achievement Award in Research. Congratulations to Prof. Arabi in the other forum. He actually implemented an automated screen, basically a screen in the background of EHR that look into certain criteria, but basically it alerts the nurse, and the nurse is required to respond within 10 to 15 minutes, call the doctors will come and see the patients. Very simple, cost-free, nothing really too much exciting about it. But look at this. The nurses, when we started, the nurses sometimes take hours to respond, to call the doctors for deteriorating patients, and see how they improve over time. Now we are 6 minutes from the alert to nurse assessment and nurse escalation. The doctors used to take hours and hours overnight because they're busy doing something else during on-call. But guess what? Now we are almost 1 hour, and the standard is 30 minutes. Did that make a difference? Absolutely. Look into the magnitude of the impact. It changed the care, so the lactate measurement increased by 22%, IV fluid by more than 50%, blood culture more than 40%, antibiotics for them 45%. But does that matter? Yes. The mortality decreased by 18%, the progression to shock decreased by 17%, and the progression to respiratory failure was decreased by 12%. Cost-free. Cost-free. And we close the loop. Every day, someone from the quality and patient safety and from the screen program will actually call the physician and say, you are red, you did not respond. Why you're not responding? And with this continuous improvement and giving a feedback for the physician, there is a very significant improvement. I'm going to stop here because of time, but I wanted to summarize by this. Diagnostic errors are a significant global concern, and we are here in Saudi Arabia, no exceptions. We share the same challenges and the same opportunities. It is a time to get the whole system focused on diagnostic safety and address diagnostic error aggressively. We must begin somewhere at a different level, and thank you for the Saudi Patient Safety Center for leading this. We're expecting a lot of work to come out soon. The journey may seem complex, but we are up to it. We can make it, and hopefully next forum, inshallah, we'll see numbers that really encouraging. There are a lot of opportunities, and every one of us is responsible. Thank you so much.
While we're waiting for the next setup, I would like to invite our audience, if you have any question, we can receive one question. If anyone has a question, they can raise their hands. Anyone from our audience have a question for Dr. Ali Al-Khathaami? Yes, we have one question here.
Thank you, Dr. Ali, for this very informative lecture. Actually, we learned a lot. I'm Dr. Abdurrahman Al-Saib from National Guard before. Actually, during our medical school, our mentor always said, what's your job as a young physician in the future? He said, diagnosis. And then he asked us, what next? We said the treatment. He said, no, diagnosis. And he asked us third time, what is your job in the future? We said treatment. He said, no, diagnosis. So he said diagnosis, 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 then treatment. I think this diagnosis is very important. But I see some on your slide that is something is very nice application, but this sometimes is difficult to apply this, and especially here in our nation, because like reporting a diagnostic error, this means as shakwa, and this is mean court. I mean, so nobody will expose himself for this is extra, unless is the way that is become like a secret. I reported, but become a secret, and this is to not to punish the physician, but at least to learn from it, as you said. So I think this is we need some modification for this is diagnostic error. I think this will be applicable in the future, but with some changes, inshallah. Thank you very much, Dr. Ali.
Have the mic. Thank you so much, Dr. Abdurrahman. You're a great mentor and great colleague and friend. I think that's part of the resistance. And that's part of the people, you know, being uncomfortable with calling things by its name, right? Now, what we have done in National Guard to you know, promote reporting these things, we have anonymous reporting. So it doesn't show who reports and why. But if we also think from it from different perspective, the ethical commitment and the ethical obligations that we have to report these things. And I think the whole idea is not because what happened in the past, it's because to prevent it from happening. It could happen to you, to me, to relative, to beloved one. And I think we just need to push people, and will make everyone comfortable to speak about it. And I remember safety reporting system when it started long time ago, 15 years ago. It's like shakwa, right? It's like, it's, عيب إن الواحد يبلغ ولا شيء من القبيل. But I can tell you now, we have almost reaching 50,000 SRS every year. And some of them are related to diagnostic error, to sentinel events, to harm. So unless we promote the transparency, the honesty, and we own it, and we hold ourselves accountable to it, we will not move forward. Is there another name for it other than diagnostic error? I don't know.
Thank you so much, Dr. Ali. Thank you very much.